So welcome back, and we get to finish off this day. This is going to be a climax to welcome Dr. Diana Farmer to give our Schilling lecture. But before I introduce Dr. Farmer, I want to add just a couple of comments that Dave Flum said it perfectly, with accolades to the residents, fellows, and students who presented, and to the mentors and discussants that made today really special. I think you really nicely emphasized the mission, the community, and the celebration of what's important to us. And you thanked all the right people, except yourself. So Dave Flum is the brains and the inspiration behind what we have achieved today. And he's the associate chair for research, and I turn to Dave for all things regarding to our academics, and he keeps us on the right track, and he's a big part of that culture and vision that we have. And you're great up here, you're great at leading this day and making it what it is. Thank you, Dave. And so now I want to introduce Dr. Diana Farmer, who is our 23rd Schilling professor. And we're really pleased to have you here, Dr. Farmer. Dr. Farmer is the Pearl Stamp Stewart Endowed Chair and the chair of the Department of Surgery at UC Davis, a position she's held since 2011. She's also the Surgeon-in-Chief at UC Davis Children's Hospital. And when I go back over some of Dr. Farmer's older history, I see some that is remarkably overlaps with some of my own. After college, she was a marine biologist for a few years. And when I went into college, I wanted to be a marine biologist, and then I was worried I wouldn't be able to pay my student loans, so I decided that I would be a doctor just a little sooner in terms of going to medical school than you did. So Diana was at Woods Hole, was at Stanford, was in Bermuda. That was probably rough as a marine biologist, then redid pre-med and ended up here at the University of Washington, School of Medicine for medical school. So Dr. Farmer has a great link with us as being a medical student here at the University of Washington. And in fact, she then stayed on. There's going to be more in her story, and I don't want to take away her story that she's going to be telling, but she was a surgery resident here, and then I looked at the timing of that, and I was thinking, let's see, that overlaps with David Byrd, Mark Meisner, Hugh Foy, Lori. So, and I was thinking, Dr. Farmer might be a source of some good inside stories about some of our senior faculty members now. And then I'm thinking, who is on faculty? And I'm thinking, Ron, Patch, Lori again. There's a couple of things that I'm going to tell you to try to seek out Dr. Farmer for. One of them is for inside dirt on what it was like in the 80s in UW surgery. So a mistake that we made, however, is Dr. Tapper encouraged her to do research, and she went to UCSF to do research. And a remarkable irony that we were discussing, at UCSF, there was a resident research day like today, and she won the best research prize as a UW surgery resident at UCSF, which is wasn't a good idea. That's not popular. And I thought that maybe that was why she then left UW and ended up at UCSF. It's more complicated than that, which we might learn about or might not. But anyway, Dr. Farmer ended up doing the rest of her residency at UCSF, and then did her pediatric residency in Michigan, and then returned to UCSF, where she worked for 13 years doing the normal advancement and normal accolades before they recruited her to UC Davis, where she is now as the chair. So Dr. Farmer here as our visiting professor represents what we would say is the old school quadruple threat, that we say doesn't really exist anymore. Most of us don't think that we can accomplish that. But as a clinical surgeon, she's renowned as a leader in surgery for congenital anomalies. As a scientist, she's done seminal work in prenatal surgery for spina bifida and leads a major NIH study of the management of myelomeningocele. As an educator, I got tired of looking on her CV at how many times she won the teaching award in the Department of Surgery at UCSF. It was every single year. And mentorship of dozens of students, residents, and faculty. And then in terms of leadership, that fourth part of the quadruple threat, just if I look at where she is now, besides being chair of an important department, she's the president of the American Paediatric Surgical Association. She's the chair of the American College of Surgeons Board of Governors. She's also the chair of the Society of Surgical Chairs. So it's remarkable leadership accomplishments that she holds now, and yet she took the time to come and be with us today. Those are great accomplishments, but those accomplishments often belie who the person is behind that. And what I know and what I've heard from those that work closely with Dr. Farmer is she is the model, the role model of selfless leadership that we talk about here and that we aspire to. Leadership that is about promoting your team, about caring more about the team you're leading than for yourself. And everything I've heard about Dr. Farmer represents that. And I think that an aspect that's inspiring, and when I think about our residents and faculty that are here, many of us struggle, including myself, with the work-life balance, work-life integration, and particularly when we're dealing with two-career families. And one of the things that I think is really remarkable, and I hope that some of you, particularly residents or junior faculty, will seek out Dr. Farmer and talk with her about, is listening to her and her husband, Chico, who talk about all the compromises that they made for each other while going through all the processes of being a resident and getting jobs and moving to different locations. And I know she's going to be talking about some of that, but it's an example of how we work together and how it's a journey, and the joy is in the journey, not just in the destination, which we talked about last night. And I think that Dr. Farmer represents that, and it's an inspiration to, I know, all of the young people who are trying to figure out, how do I figure out where me and my husband go for the next stage of fellowship or for a career. And we were having a discussion at lunch about that. So Dr. Farmer, thank you for being here. We're thrilled to have you as our Schilling professor.
Well, thank you so much, David, for that really humbling introduction. I am truly humbled to be here. UW has such a special place in my heart. A couple of times today, I've really just been choked up to think about how it all started 35 years ago. I clearly might have been voted least likely to succeed by many people in this room. But many of those people gave me a chance when it was unclear what my trajectory would be. For that, I will always be grateful. In addition, I met my husband here. Actually, we were talking about exactly which floor it was on in the Children's Hospital where we sat on that ledge and had that fateful conversation. And I'm also proud to say that I knew that my son-in-law, who lives in Seattle, was the roofing contractor who fixed the Husky Stadium roof when it fell down, but I didn't know that he brought it in on time and on budget, because that he didn't tell me. He did tell me that subsequently they've done almost every roof in the UW system since then. But it is truly humbling for me to be back here, and a real honor to come home. Sir Isaac Newton once said that if I have seen further, it is by standing on the shoulders of giants. That sentiment, that scientific discoveries do not occur in a vacuum, but are rooted in the fertile intellectual soil tilled by others, resonates with me this afternoon as I give this important Schilling lecture. Dr. Schilling, in fact, was the department chair when I was a medical student here. He was one of the indisputable giants at the University of Washington Surgery, who modeled the notion of clinical excellence coupled to scientific inquiry. The model of that continued. I remember very clearly as an intern subsequently the great terror that came for Carico rounds. But that terror as a student and an intern prompted the incredible discipline to knowing the answer and being excellent. I also remember Ron Mayer's red pen, a lot of Ron Mayer's red pen, all over my H&Ps as a medical student as well. Dr. Pellegrini indeed was my chief of GI when I was a resident in San Francisco, and I was very happy. I remember getting calls from some of you who knew I knew him in San Francisco when he was looking at the job and saying, yeah, he'd be a good guy to bring up for you all. He's a safe bet. So all of these great leaders are role models for all of us that choose to aspire to careers as surgeon scientists and to follow in these footsteps, even if we come to this path in a roundabout way. My professional journey has indeed been full of surprises. And today, I will tell you some of the ways that chance meetings and unexpected opportunities have led me to where I am today. Indeed, serendipity, a word that I heard mentioned earlier today. This journey, for sure, has not been a solo voyage. Every step of the way, I have been in the company of established and up-and-coming surgery giants who have inspired me and helped me see farther than I ever would have thought possible. Just after medical school at the University of Washington, I had the opportunity to study medicine in Asia, Singapore, as a loose scholar. Now, that's L-U-C-E, not L-O-O-S-E, which is very important because my father said to me, "You've always been a loose scholar." And interestingly, at that time, now 35 years ago, most people advised me not to do this if I wanted to be a surgeon. That this overseas stuff was only for those medicine and pediatric types. Sorry, Sonny. And that would never get into a serious residency like surgery if I did that. Well, on the contrarian advice of Dr. Kai Johansson, a vascular surgeon, chief of vascular surgery at Harborview at the time, he said, "Are you crazy, lady? This is a world-class opportunity. You should take advantage of that, and we'll figure the other stuff out later." And indeed, well, I went to Singapore. And over the course of an amazing year, I worked in the Department of Surgery at the National University of Singapore. I studied traditional Chinese medicine, and I even became certified in acupuncture, because at the time I wasn't sure if I might actually need a good backup plan. This early international experience, unbeknownst to me at the time, would later become the springboard for my work in global surgery. I came back to the University of Washington with a little bit of very critical help from my chief resident, Dan Ledbetter, a long time attending in pediatric surgery here. I was wavering and thinking about going into anesthesia because it was a crazy thing for a woman to think about going into surgery. And Dan said, as I was listening to him talk about his cases when he came home, specifically I remember from the burn unit, he looked at me and he said, "You are not an anesthesiologist. You need to do surgery." And he and Kai found a way. My time overseas was going to take 2 years out of the program, and they found a way to make a spot for me in surgery. And I'm now far enough along that I'm willing to go public, as I said last night, that I actually never matched in surgery. And another little secret is I didn't actually get paid either, but that's water under the bridge now. So following my return to the University of Washington, I came to know David Tapper, who was the first pediatric surgery giant to give me guidance. And he encouraged me to follow my interest in scientific research, which again, at that time, was somewhat unusual, both for surgeons and for women. In fact, as I recall, there were only 3 women on the wall. You know, every surgery program has a wall. In fact, I remember Karen Geis being the most recent woman that I had seen on the wall at the time. Along the way in my scientific journey, I have discovered that scientific research is more complicated, more beautiful, more messy, and more rewarding than all of the elegantly written journal articles would lead one to believe. This truth is nowhere more evident than in the burgeoning field of regenerative medicine. Regenerative medicine seeks to harness the therapeutic potential of our own stem cells to treat a broad range of diseases. Tonight, I will briefly describe some of the key points in the evolution of regenerative medicine that correspond to my own research career, from my early research on cellular immunotherapy for cancer to my current work on in utero cell therapy for spina bifida. In research, we strive for objectivity. However, there is no way to completely remove the subjective from science. Scientific progress is inspired by human dreams, driven by human will, redirected by human politics, saved by human faith, and sometimes doomed by human hubris. Those untold stories, those funny, frustrating, unbelievable moments that we leave out of the textbooks and the manuscripts form the everyday fabric of surgical science. I will pull back the curtain a bit on surgical science in all its warty glory and share some of the lessons that I have learned along the way about surgery, about stem cells, and about science overall. As a general surgery resident, I made my first attempt to join a surgical science laboratory, Mike Harrison's fetal surgery laboratory at UCSF, and but it was not to be as I thought. Al DeLormer had made the first animal model of fetal surgery and recruited Mike Harrison up there, who now is considered the father of fetal surgery. The Harrison lab seemed ideal. Here, an aspiring pediatric surgeon could conduct research under the tutelage of an established great, who was at the time laying the foundation for a whole new branch of pediatric surgery. However, that was not to be. The lab did not have any space for an additional resident, and I was, in fact, an outsider from UW, so I didn't get into the Harrison lab. But I needed to follow my husband, who was now doing his anesthesia residency down there. So Dr. Harrison kind of took me to the guy next door who didn't have a fellow in his lab and said, you know, maybe you should do cancer immunology. And I'm like, okay, I don't really know what cancer immunology is. Well, while I was disappointed, I did not realize at the time that this work on cell therapy, which I can now think of as an early foray into a field that could be viewed as a predecessor to stem cell therapy, would ultimately set the course for my own career. Serendipity. The lab ran the extramural arm of Steve Rosenberg's National Cancer Institute trial of autologous lymphokine-activated killer cells, LAC cells, for those of you who are old enough to remember, to treat metastatic melanoma and renal cell cancer. We lymphophorésed patients. We harvested their white blood cells. We cultured those in roller bottles just in our regular lab, no GMP facilities, no FDA. And we spun those down and re-injected them into patients on the hopes that these cells would home to the cancer patients. And by studying the cellular profile of the patients who were treated with these LAC cells, we were able to identify that the effector cell was actually an NK cell. That discovery served as the foundation for ongoing research in the role of NK cells in tumor suppression and developing NK-based cell therapies today. Over the past 20 years, this kind of research has spurred a number of important discoveries in cancer therapy, including two of the talks that you heard today about engineering patient-specific T cells for deploying novel drugs and radiotherapies that impact the function of the immune system. Indeed, in 2013, which was, again, almost 30 years later from when we were doing our early work, Science called immunotherapy the breakthrough of the year. On a personal note, I found it a tragic irony that Dave Tapper, who had first encouraged me to explore an interest in scientific research, later developed metastatic renal cell cancer and was in fact treated with IL-2 and LAC cells. At the time, conventional therapies were not effective, and sadly, as most of you know, even with this experimental therapy, he succumbed to his disease just after serving as the APSA president. I spent 2 years working in the immunotherapy lab, and at the time, I became friends and colleagues with two of the junior members of the Harrison lab, Jack Langer, Tim Krummelholm, Mike Longacre, one of your previous Schilling speakers. Each had been assigned a project. At first, it seemed as though Jack and Tim had landed the plum projects, fetal surgery for gastroschisis and hematopoietic stem cell therapy. Longacre's project, in comparison, wound healing, seemed decidedly less interesting, with all due respect to Dr. Schilling, and certainly seemed less likely to jumpstart a career as a surgeon scientist. Well, fast forward today, Mike is now primarily a scientist. He's also the vice chair and the co-director of the Institute for Regenerative Medicine at Stanford. And Mike Longacre is arguably one of the most prolific surgeon scientists in the world. His trajectory, to me, was powerful lesson number one, that there is great potential even in a seemingly unglamorous project. Or in the words of the great Mick Jagger, you can't always get what you want, but if you try sometime, you just might find you get what you need. A recurring theme in the rock and roll world of surgical science. My early research years also taught me that science was not as pure and as fair as I had previously believed, and that competition can be fierce. In fact, I think it's much more fierce in science than it is in clinical medicine. Grants do not always get funded on merit. Who you know can be more important than what you know. And some people will go so far as to sabotage another's work in order to advance their own. One experience had a particularly profound impact on me. A veterinarian researcher down the hall appeared to be on the verge of an important medical discovery, perhaps a treatment for diabetes. And the powers that be decided that this research was too important to be left to a mere veterinarian. So in order to prevent him from carrying his project through, over a weekend, they changed the locks on the door to his lab, and they took control of his data and project. Now, there very well may have been a complex backstory to that situation. I suspect there was. But what I saw as a student investigator were politics and subterfuge. my naivete shattered, I became somewhat disillusioned with science. Where were the integrity and objectivity that were supposedly at its core? My disillusionment taught me life lesson number 2, that leaders and mentors and senior investigators always have eyes on us. It is important to realize that our students are carefully watching. What we model about honesty and integrity in research, not what we say, is what they will learn. In my 3rd year of research, again, set up really to follow my husband, who was now doing his pediatric anesthesia fellowship at CHOP, I ended up at DuPont Merck Pharmaceuticals in Philadelphia. In addition to continuing my research on cellular immunotherapy, because DuPont was making the cell washer that was being used in Rosenberg's tumor-infiltrating lymphocytes at the NCI, I also served as the assistant medical director of cancer clinical trials. Kind of still hedging my bet on whether this surgery thing was really the right way to go. I gained invaluable experience, however, running large-scale, multi-center clinical trials and explored what a career in industry would look like. I even traveled to Italy to help establish technology, our stem cell technology, at a Sicilian Cancer Institute. Having had little international experience outside of my loose scholarship year in Singapore, I was energized by the idea of getting a chance to work once more in another country. There I learned again that care always occurs in a local cultural context, and that money significantly influences the distribution of healthcare resources in sometimes illogical ways. Indeed, the sophisticated, state-of-the-art cancer center that we helped develop in the far reaches of Sicily was evidently intended for the use of those special Sicilian families. Clearly, it was the Italian mafia that built this high-tech center on the remote outskirts of an otherwise rural and sparsely populated island. During my time at DuPont, however, my respect grew both for the scientists and the science in industry. An enormous amount of time, energy, and money were devoted to basic scientific discovery, and smart, good people were working hard to make a difference. In some part, this investment was driven by a simple truth, that the best way to succeed in industry is to have a great product. And on a day-to-day basis, I came away thinking that industrial science was just as likely to be rigorous and honest as academic research. However, I also saw that once a product moved into the marketing and regulatory approval phase, money drove behavior. Just as in academia, the higher the stakes, the more intense the politics. I came to the eventual conclusion that it is the leader of a company who plays a vital role in determining its culture and its practices. The very best leaders are those who can balance the need for fiscal stewardship with doing the right thing, be it to produce safe and effective products, to disseminate and produce honest data, or to promote new procedures only for those who will truly benefit from them, a lesson we've seen recently in Seattle. At the end of my year at DuPont, I returned to UCSF to finish my general surgery residency. I applied for pediatric surgery fellowships, and come match day, I found that I matched at the Children's Hospital of Michigan in Detroit. I almost didn't go. Offered a spot at UCSF's cardiac surgery program, I wavered. Dr. Arvind Philippart ended up being the deciding factor for me, because instead of telling me that I couldn't turn down his fellowship, he said, this is the most important decision that she needs to make. She should do what's best for her, and if she wants to be a cardiac surgeon, we'll figure this out. And I thought, ooh, this guy sounds pretty reasonable. Here was someone who would work with me to be the kind of surgeon and researcher I wanted to be, not just who he wanted me to be. Here was someone who respected my autonomy and was willing to give me the space to use it. I accepted the fellowship. Finding the right mentor is really important, as discussed today. Literature on mentorship shows that those who receive mentorship are promoted earlier, are more likely to follow their initial career goals, and experience greater fulfillment in their career. Over the past decade, a variety of surgical journals, including JACS and archives, have featured original articles reviewing the data on the importance of mentoring for junior surgeons as they embark on their careers. As mentioned earlier, your mentors can be senior surgeons or the department chairs. They can be from different specialties or subspecialties with complementary research interests. Whoever they are, your mentors should push you to push yourself within the context of your values and your aspirations for your life. The best mentors will not solve your problems for you. Instead, they will encourage you to establish your own independence and learn by personal experience. It is important to keep in mind that mentoring is not a one-way street, where you, as the junior surgeon scientist, receive wisdom from a benevolent mentor. As a mentee, you bring your questions, your desires, and your drive to the table. You work with and sometimes for your mentor, benefiting from their knowledge and experience. You also pay them back with your insights, your feedback, and sometimes your time on their projects. The most successful mentor-mentee relationships are very much reciprocal and last for a lifetime and are some of the most valuable parts of what we do as surgeon scientists. When I then joined the Pediatric Surgery Fellowship at the Children's Hospital of Michigan, I benefited from the surprising fact that the Children's Hospital of Michigan, again, completely unbeknownst to me, was an unexpected epicenter for fetal intervention and research. Indeed, it was really the first fetal treatment center outside of UCSF. I had no idea. At Michigan, I worked alongside Alan Flake, who had preceded me at UCSF, and was indeed now recognized as the father of in utero cell therapy. Mark Johnson, who is now head of maternal fetal medicine at the Children's Hospital of Philadelphia, Mark Evans, a renowned geneticist and expert in reproductive technologies, and Ruben Quintero, a controversial but leader in MFM, were all there. A wide variety of congenital diseases may indeed be amenable to in utero cellular treatment. Flake and a number of groups have laid the groundwork for a new era of treatments for hemoglobinopathies such as thalassemia and sickle cell disease. Others have proposed that in utero therapy may provide the unique ability to prevent tissue damage in patients with cystic fibrosis. It's currently being applied in utero for osteogenesis imperfecta. While I was there, I witnessed Alan Flake doing the first in utero cell therapy for severe combined immune deficiency. He injected the father's bone marrow cells 3 times into the abdominal cavity of the fetus, and when that baby was born, he had true chimerism and was a bubble boy who did not require the kind of intense therapy that had previously been required at the time. Stem cells may also be used for in utero tissue engineering to repair or replace damaged or non-existent tissues. Investigators have suggested that in this capacity, stem cells may be used to repair congenital diaphragm hernia or tracheal defects before birth. Over my time in Michigan, I came to learn lesson number 3, that it is not prestige or location alone that predicts discovery. It is the people. It's having the accumulation of the right people at the right place at the right time that is the single most important factor in this mysterious alchemy of scientific discovery. I also learned that a few early wins keeps you going along the tedious repetition, the inevitable hiccups, and the days when the experiments just don't work. Just after my fellowship, I joined a team of cardiac surgeons who had developed an open heart surgery program in Senegal. Prior to this experience, I thought of public health as limited primarily to sanitation and infectious disease control. I soon learned that surgeons can play a vital role. while indeed it may be more cost-effective to vaccinate against measles and prevent rheumatic heart disease, for those children who already have the disease, they need to be treated surgically. This child could then be transformed overnight from being a burden on society to being vibrant and productive members of a society with many years ahead of them. I returned to the United States after this brief foray, determined to find a way to incorporate global surgery into my early career. But at the time, it was one of those things you never dared put on your CV. Just like being told that if I went to Singapore, I would never match in surgery. It was one of those things you did on vacations, and you did sort of sub rosa so that it wouldn't detract from the part of you that was a serious scientist. I have found over time that one of the best ways to contribute in global surgery is to be the shoulders upon which new and upcoming giants stand. I'm proud to say that there is now a vanguard of surgeons pushing for essential surgery to become a core element of international health. And much of this work has been led by the great strides performed here at the University of Washington and led by Charlie Mock. I believe that our colleagues' prominence in this new and evolving paradigm is due to the fact that fundamentally, surgeons appreciate viscerally the unfairness of a child dying from a treated congenital anomaly or a young person dying from trauma just because she happens to be born in a limited resource country. For those of you who have worked or traveled in low and middle income countries know the burden of surgical disease is devastating, particularly for children. There's no easy fix for this particular Gordian knot. Different approaches to improving surgical capacity in low resource settings, such as organizing humanitarian trips, forging academic partnerships, and developing cadres of allied health practitioners to treat a wide range of conditions, all represent viable, complementary steps in the right direction. What is clear is that improving accessibility and the quality of surgical care in low and middle income countries will substantially reduce mortality and lifelong disability. We surgeons have played a leading role in developing the new and rigorous ways to evaluate the burden of surgical disease and demonstrate the cost effectiveness of surgical interventions, as highlighted beautifully in the presentation this afternoon. These leaders are generating data that are vital to speaking the language of the World Health Community and translating medical realities into policy initiatives, which is why it's so important to get that basic science in global surgery, to speak that MPH language. While I have made some contributions to this field, my greatest achievements have been in cultivating training programs both at UCSF and now at Davis to help aspiring young surgeons that want to incorporate global surgery into their careers. Contributing to global health in any capacity, as a clinician, as a researcher, as an educator, or as a mentor, changes your perspective on medicine. It reminds you of why you are a doctor, to help others in the most fundamental way possible. Participating in global surgery also underscores why the world needs physician scientists. We are doctors because we want to alleviate suffering. We conduct research in order to better achieve this lofty goal. This uniquely translational approach pushes us not just to discover for discovery's sake, but to discover so that we may help. And it's that singular focus is just as true of global surgery researchers as it is and was true for the leaders of fetal surgery research. The importance of having the right people at the right place at the right time was no more better demonstrated than in the development of the new field of fetal surgery. Fetal surgery could not have been developed at a freestanding children's hospital. At the time, UCSF had everything in close proximity. If you've ever been there, space is not their big asset. The ultrasound experts, the pediatric surgeons, the maternal fetal medicine specialists, the geneticists were all sort of stuck on top of each other in an amazingly creative scientific milieu. Mike Harrison, a true giant, was a visible, visionary, and charismatic leader, as you can see here, for fetal surgical research. Over the 3 decades since he performed the first fetal surgery for posterior urethral valves, the story of fetal surgery has been one of remarkable success despite being punctuated with grand failures too. Over 1,000 fetal operations have been performed, and at least 10 highly qualified fetal treatment centers have been developed over the time. Let me see if I can just... Wait. 10 fetal treatment centers have been developed, both domestically and internationally, that I would say do the full range of fetal surgery now. It's hard to believe. Come on, you can do it. We tested these. Let's just see. Try one more time. All right. To my knowledge, there have only been 3 maternal deaths in over this now 30-year period, which is an amazing good result for what is a high-risk operation. And countless fetal lives have been saved for otherwise desperate families. In fact, it should now be considered the standard of care to deliver a baby with an obstructed neck mass by ex utero interpartum treatment, the exit procedure, to treat twin-twin transfusion syndrome. This is a view of the inside of a placenta with hypertrophied blood vessels, with laser ablation, or to do in utero resection of hydropic tumors. Historically, only life-threatening congenital anomalies were treated before birth, as only then could you justify the potential benefit for the otherwise doomed fetus as one that outweighs the risk to the otherwise healthy mother. As maternal safety continues to improve, we have the opportunity to develop fetal surgical treatments for more benign conditions that cause severe morbidity but not mortality. And just as society easily accepts living-related liver transplants as an acceptable risk for an otherwise healthy donor, it is not beyond imagination that society will in the future accept fetal treatments for things like cleft lip or gastroschisis as an acceptable risk for the mother. As a faculty member intimately involved in the early days of fetal surgery, I loved the research. However, I recognized and understood that our successes always came with a price. With great discovery comes great competition for grants, for leadership on grants, for honors and awards, and for promotions. The most important advice I can give regarding these politics is to make comrades of your competitors, to be gracious when you win, to try to find forgiveness when treated unfairly, and to thoughtfully choose when something is worth a fight. While I in no way perfectly navigated these choppy seas, I did eventually steer myself to a place where I could begin my own research, which focused on the first of the benign conditions to be treated before birth, myelomeningocele or spina bifida. I knew that spina bifida was a disease that would catapult fetal surgery to widespread use. It is common, it is tragically debilitating, and it is highly visible. If you've been to any developing country and seen the kids in the little red wagons with the big heads, those are kids with untreated spina bifida who survive. While Muley and Adzik's pioneering work in neurologic function and my work on the reversibility of the Chiari malformation in the sheep models showed great promise, its application to human medicine was proliferating very rapidly in a somewhat, I would say, less than ideal circumstance. I was convinced that we needed to definitively prove that the treatment was truly effective in humans before more women's lives were put at risk. Because if you think about it, every baby is born incontinent and can't walk. So it's very hard to prove, and all the mothers believed that in fact their babies were helped. Drawing on my work with large-scale clinical trials at DuPont, I knew that in order to run a clinical trial with adequate numbers, we needed an outcome variable that was independent of the level of the lesion, and the need for ventriculoperitoneal shunting satisfies those requirements. I drafted the proposal and submitted the first grant for what was ultimately the management of myelomeningocele study. The MOMS trial, initially led by Mike Harrison, Scott Adzik, and Joe Bruner, was a randomized controlled trial to compare prenatal repair of myelomeningocele, same operation before birth, with standard postnatal repair. And while the politics of the MOMS trial could constitute a lecture in itself, we nevertheless persevered, and after 8 long years, anticipating, frankly, that we would be shut down for failure to recruit, the trial was actually stopped early for efficacy, very unusual, by the Data Safety and Monitoring Board. The MOMS trial showed conclusively for the first time that fetal surgery resulted in better outcomes. Fetal patients were significantly less likely to die or have a shunt placed at 12 months and achieved significantly higher composite scores of motor function and mental development at 30 months, 2.5 years. Only 40% of the fetal patients required a shunt, whereas 80% of the patients who did not get fetal surgery required a shunt at a year. Fetal surgery also improved the likelihood of independent ambulation. Our powerful results were published in the New England Journal in 2011, and I remember sitting in the hotel room applying for my job at UC Davis when we were on the phone with the New York Times and the Washington Post and everybody who wanted this, and I thought, this is surreal. MOMS trial was named the Trial of the Year by the Society of Clinical Trials in 2011. And in fact, barring any contraindication for fetal surgery, prenatal repair should now be offered for eligible patients with spina bifida. What really intrigued me, however, was that the MOMS trial showed for the first time that prenatal repair could improve motor recovery, could improve paralysis. We always thought that this paralysis was fixed at 6 weeks gestation with no hope for improvement. There's been very little progress made on actually improving paralysis in adult patients. And although it was improved, the disease was not cured. The majority of the patients were still unable to walk unassisted. My previous experience with cellular therapy and the parallel developments in postnatal tissue engineering led me to hypothesize that stem cell therapy could hold the key to improving these outcomes. Think about it for a minute. The gestational environment is hypothetically ideal for cell-based therapies, since the natural function of a fetus is to promote tissue remodeling and tissue development by native stem cells. I mean, the fetus, after all, is a bunch of stem cells. So I started searching for a solution in 2008 and have continued this day at UC Davis as the director of our now surgical bioengineering lab. As a fetal surgeon, I have always been impressed by the placenta. Here is the most amazing and mysterious organ. It is composed largely of fetal tissues. It develops and becomes senescent over the span of just 9 months. It protects the fetus from being rejected by the mother, is an endocrine organ in its own right, and it is an amazing model of angiogenesis. I personally think that all the vascular surgeons in the world should be studying the placenta. The amnion layer of the placenta had already been used in ophthalmology and wound healing. And we once had to use a piece of amnion to help cover the fetal back because we didn't have enough tissue. And curiously, that child had a better than expected outcome. So we marshaled our research efforts to focus on investigating the placental as a source of treatments to supplement prenatal MMC repair. And this has been the focus of my laboratory for the past decade. Collaborating with neuroscientists from the Brain and Spinal Cord Injury Center at San Francisco General, because they think about spinal cord injury all the time, and tissue engineering colleagues at the Berkeley Department of Bioengineering. We initiated studies on placenta mesenchymal stromal cells, or PMSCs, from the chorionic villus. Now, those of you who've had kids and probably have heard a little bit about chorionic villus sampling as a well-established technique that until this point was a diagnostic tool. As cell-free fetal DNA has now become more popular, CVS is no longer required most of the time for diagnosis, but imagine its potential to be used for therapy. CVS enables providers to access autologous fetal stem cells as early as the first trimester. Ex vivo expansion, or genetic manipulation of CVS-derived stem cells, could occur within the limited time window between CVS and the time we do fetal interventions. In light of the severe lifelong morbidities that are associated with birth defects like myelomeningocele, it might be worth the risk. So collaborating with our team of stem cell scientists and engineers from Berkeley, we began to develop CVS-based in utero treatments for myelomeningocele. We have established reliable explant cultures to isolate placental stem cells from placental tissue. And these cells express the usual characteristic mesenchymal stromal cell surface markers that you can see here, and they don't express the markers for endothelial and cells. They also express a wide variety of intracellular markers and transcription factors that have been previously associated with pluripotent cells and whose, or embryonic stem cells. So they are a little bit more early, if you will, than our typical adult bone marrow stem cells. Indeed, they can differentiate into both mesodermal and ectodermal lineages, whereas in fact, bone marrow cells can only differentiate into the typical osteogenic, chondrogenic, and adipogenic lineages. Again, we have, and others have described this, made this observation about placental stem cells. And this greater plasticity of the stem cells may in fact be derived from the fact that they are younger and more primitive. So adult bone marrow stem cells already had made their clinical debut in spinal cord injury, so we hypothesized that the PMSCs might work better for congenital spinal cord injury. We conducted a pilot study in sheep that included 2 natural sets of twins, which were divided such that one twin would receive the stem cells and the other twin would just receive the vehicle. For this particular study, the PMSCs were loaded onto a hydrogel delivery vehicle and applied directly to the neuroplaque during in utero repair. Within 48 hours after birth, I'm going to really be mad if this doesn't play. Okay. So I'm actually going to, so forgive me while I'm going to try once more, but I'm going to get out of the slide to make this work. I can't believe we checked this. So I want to go straight to the folder, if you want to help me for a minute. Shoot, where's the folder? Here, where's the, did we not take the, put the whole folder in? No, I think, let's try for the presentation. Yeah, so I think if the video's not in here. So I'm sorry, shouldn't have taken that piece out. What this shows, and in fact, I'm just going to run get my disc. Thank you. Because sometimes, indeed, a picture is worth a million words. What we showed was that the lambs treated with the PMSCs evidenced markedly improved motor function compared to its identical twin. Both the cell-treated lambs exhibited almost completely normal motor function, indistinguishable from that of our controls. In contrast, the matrix-only lambs evidence severe to moderate defects. Our histologic analysis corroborated these powerful clinical findings. The PMSCs treated animals appeared to have increased number of preserved neurons as well as the density of neurons in the spinal cord. These preliminary findings suggest that PMSCs may act primarily by neuroprotection as opposed to preserving the gross quantity of spinal cord tissue. Our concurrent in vitro studies of the PMSCs reveal that they secrete a broad range of pro-healing, immunomodulatory, and angiogenic cytokines. Of particular note, you can see that they secrete significantly more BDNF, a growth factor that's critical to the development and repair of the nervous system, than do adult bone marrow cells. And our ongoing research suggests that the PMSCs act by a paracrine mechanism to rescue neurologic function in the sheep. Other types of mesenchymal stem cells have been shown theoretically to act on target tissues via a similar paracrine activity. I have to say that it has been, if we are able to confirm these findings, and we have so far seen no adverse immune reactions in any of our fetal sheep, we are now starting to develop an allogeneic PMSC product, an off-the-shelf treatment to potentially use to treat spina bifida. And this will allow us to reduce the procedural risks of doing chorionic villus sampling and using autologous cells. Last week, we recently discovered that there is a naturally occurring model of spina bifida. It turns out that bulldogs are a relatively inbred breed and develop spina bifida. Most of the time we don't know about this, but there are many sort of rescue groups that are moving to save these bulldogs who have their little bulldog wheelchair and their little bulldog diapers, and they are cute as can be. So we were able to get a set of 11-week-old twins. We did this just last week, and in collaboration with our colleagues at the vet school, operated on 2 of these patients under a compassionate use protocol because they're patients in the veterinary world, and we put some bulldog placental stem cells in the repair of these patients, and we should hopefully know something in about 6 weeks. So I'm pretty excited about that. I have to say, it has been an absolute privilege to work over these many years from my humble start here at the University of Washington at this such exciting crossroads, the place where fetal surgery intersects with tissue engineering. While relatively few investigators are actually actively working on fetal regenerative medicine, the growing abundance of impressive work in adult regenerative medicine provides us with a wealth of transferable knowledge. In my opinion, the fetus is the perfect target and the perfect source for cellular therapies, be they to induce tolerance for a future organ transplant, to cure hemoglobinopathies before birth or to replace deficient tissues. The future of this crossroads is incredibly bright, and I imagine years of exciting work for interested young scientists in the audience. We can barely imagine today what treatments might be possible, but I think treating disease before birth is the next frontier for many, many kinds of disorders. The fetal origins of adult disease is also a new field of medicine that's being actively explored. In conclusion, as surgeons, we can be very proud of our scientific heritage, of our strong tradition of mentoring, of our persistence in finding ways to tackle the seemingly most intractable challenges, whether they be at the level of the fetus or at the level of a health system in a low-income country. We all know that scientific research is simultaneously frustrating and compelling. It is more than about chance and more than about planning. It is about persistence in the face of failure. It is about recognizing and creating opportunities. It is also about politics and knowing how to deal with the people and the system. Over the course of my career, I have lost my early naivete about the pure integrity of scientific research. Yet every single time that I've become discouraged or disheartened, I have found something new. Some new research direction, some new employment opportunity, some new collaborator, or some change that has reinvigorated me. And that is really the point of my talk, that even when faced with brutal disappointment or disillusionment, even when not matching in surgery, we have the capacity to maintain that joy of discovery. And that joy, and the joy that it will eventually bring to our future patients, is what fuels the surgeon scientist. Or in the words of the great Winston Churchill, and modeled for me by Mike Harrison, success is nothing but going from failure to failure with undiminished enthusiasm. Thank you for the privilege of sharing my magnificent scientific journey from Singapore, Seattle, Senegal to stem cells, and I hope that many of you will follow. Thank you.
See what I mean? Dr. Farmer, Diana, thank you very much. This is terrific. I want to see if there's questions. We have time for a couple of questions at least before we break for the day. So, questions from the audience? Yes.
I have a question about Singapore. You became a trained acupuncturist. Has that knowledge carried forward in any way?
So thank you. We discussed a little bit about that last night. In addition to being that ever-present backup plan, I'll say that I developed enough respect for the discipline, and I saw patients who swore that they were relieved of their migraine symptoms. And knowing migraine sufferers, nobody fakes that they're relieved of their symptoms. So I really got the feeling that there was something there. I have enough respect for it that I wouldn't practice it as a hack, kind of make it up. And I've really forgotten all of those skills. But certainly if I had a pain syndrome or significant back pain or something like this, I would consider acupuncture before I considered an operative intervention. Whether it's the 30% placebo effect, whether it's something that we don't understand, I don't have the answer to that. Lots of smart people are thinking about it. But I absolutely developed a respect for the discipline.
Thank you. It was a great talk. I have a question for you as someone who thinks about the future and sizes up the challenges that are ahead of us, how do you think academic surgery where do you think it's going? How is it going to get over the hurdles that are in front of it? And what would you advise a academic surgical department that's trying to stay strong in the future?
I'm very interested in David's question.
You know, it's a really tough question, and I really wish I could see where this puck is going to go. What I have to say is that what I know for certain is that only academic medical centers will be places that do scientific inquiry of the kind that surgeons need. You know, whether that's developing robotics, whether that's thinking about new ways to do cholecystectomies. Surgical disease is not something that lots of other people care about. Spina bifida is, you know, it was all about rehab. It wasn't. So we need surgical science to move our field forward, or we wouldn't be in the great place that we are now. That's not going to happen in our Kaisers and in our private environments. There may be other great outcomes kinds of research that they do and maybe better able to do with some of their population approaches. So I think everyone has something to contribute, but I think the fundamental translational work will have to come from preserving it in some way in academic medical centers. I think we've gone too far down the business road to medicine. I think there was a trend to have all MBAs and people running healthcare systems, and I think that pendulum has swung too far. I often see in my international work that many of the solutions that we think we're so cleverly developing for low and middle income countries could in fact be very well applied here, and that maybe some of our obsession with sterility, and I realize this is being recorded and so it's heretical to say, and so I'm going to be careful, but you know, we may not need the high intensity level that we're bringing to medicine for everything. So I think academic medicine has to survive in some way. How that's going to work with the pressures of finances and the fact that we've got to bend the curve on the GDP that we spend on healthcare. It's just, if every single person got total body MRIs and every joint replaced and your heart replaced, and you know, we could bankrupt the whole country tomorrow if we just gave all of that care today. So hard decisions are going to have to be made about how we deliver healthcare, about who accesses some of these things. But we have to preserve, I really believe that we have to preserve scientific inquiry in surgical disciplines and in medical disciplines, because we're the only ones who can do that translational work. So I didn't really answer your question because I don't really know the answer.
Well, I think that's a great place to stop. That's a great question. You've inspired us about your journey of scientific inquiry, and we've been all inspired by the residents and fellows and their faculty mentors today. I appreciate your being here. I appreciate all of you that presented today.
Well, thank you so much. I cannot, again, express enough how humbled I am to be back home and grateful for the opportunity and the chance to have this marvelous career that I would never have had without the University of Washington. So thank you very much.